we're waiting for Kathy to finish letting in our members and friends, I want to say that I appreciate everyone joining us tonight. This is our second inaugural Neela Nights. We had a very successful first evening with Brown discussing some basic lipid disorders and metabolism. Tonight, we're going to have Dr. Kirkpatrick talk to us about nutrition and coming attractions. December 7th, we're going to have Chrissy Ballantyne talk about cutting edge lipid therapy and different hot topics. So mark that on your calendar, December 7th. And the purpose of our Neela Nights is really to engage everyone throughout the year to foster education, interaction, with our colleagues, and really just keep everyone engaged in lipid management and helping take care of our patients. So, as I've said before, if anyone has any topics they would like us to bridge, we're going to plan to have Neela Nights in the second half of the year, leading right into the national meeting in Atlanta, June 1st to June 4th. So I have some ideas, but I'm always open to new ideas and thoughts as to what everybody wants to learn more about. So I think it's about 5 after 7 here. Kathy's still letting some people in, Carol. So let's give it another 2-3 minutes and then we'll get you going.
Sounds good. Thank you.
And as I said, I don't think we'd have enough squares for the entire Neela chapter of 450 plus people. It'd be a challenge. A welcome challenge, but a challenge.
I was just going to say.
Also, while Carol's speaking and presenting, if anyone has any questions, you could put them in the chat box or save them till the end, and then we can, unmute and you can ask Carol anything that you like in terms of care for your patients and nutrition, and certainly anything that you feel is a challenge within your practice. So I think that's how we'll handle questions tonight. And basically, I'm going to introduce Carol and get us going here. So Dr. Carol Kirkpatrick, who is a dear friend of mine, is a clinical scientist at the Midwest Biomedical Clinical Research Facility. She is an adjunct faculty member at the Kasika Division of Health Sciences at Idaho State University. Dr. Kirkpatrick teaches the course, Evidence-Based Lipid Practice, to students to promote an interdisciplinary approach to evidence-based lipid management. As a registered dietitian and nutritionist, Dr. Kirkpatrick specializes in cardiovascular nutrition. She is a leader in the National Lipid Association and has contributed to many of our projects and also holds other leadership positions within the NLA. She was a member of the expert panel on nutrition for the NLA recommendations for patient-centered management of dyslipidemia, Part 2, published in December 2015. She was also lead author of the NLA scientific statement on low carbohydrate and very low carbohydrate diets, and is co-chair for nutrition interventions for adults with dyslipidemia, an NLA clinical perspective that is currently in progress. So there is nothing about nutrition that Carol cannot speak to. And as all of us here have challenges in our practice, I had asked Carol to focus a little bit on how to handle the patient with high triglycerides. That becomes, frustrating for us. We're all good at LDL management, but when it comes to triglycerides, we have our own, frustrations, and certainly dietary intervention can be very helpful in that group. There have been some questions from members about when to recommend intermittent fasting and some of the other diets, which Carol could speak to. So without further ado, it's my great pleasure and really appreciate Carol taking the time. I'm part of our inaugural Neil and Nights presentation. So without further delay, Dr. Carol Kirkpatrick, it's all yours. Take it away, and thank you again.
Thank you. That was a very generous introduction. So I don't know that I can answer every nutrition question, but I'll do my best tonight. And just another little reminder that we keep getting some feedback. There's a couple people that need to mute during the presentation so that we won't have that feedback. So hopefully that works okay. Let me share my screen to get us started. Okay. So Guy actually had a really clever title for my presentation, and I kind of shut him down on that. So my title is not fun and exciting, but it is, I think, an important topic, and it really is based on questions that he had obtained from you all as the NELA member. So that is what I'll talk about tonight. It really is focusing on the questions that he had obtained from you all. So, and then we'll have Q&A at the end. I do not have any disclosures. And so these are the objectives that I will cover tonight. And the first couple of bullets will talk first through just the evidence-based nutrition guidelines that we have. And I think some practitioners, some healthcare professionals feel like it's confusing which dietary pattern we should recommend to our patients. So I just want to spend a few minutes showing the similarities of the recommended healthy dietary patterns. Then we'll delve into the nutrition interventions and other lifestyle interventions for hypertriglyceridemia, like I mentioned. And then I'll wrap up with talking about, beyond nutrition, the other health behaviors that we want to have our patients consider and facilitate in our patients to decrease the risk of ASCVD. So again, as Guy mentioned, if you have questions, you can either put them in the chat, so we'll make sure that we cover them, or hold them, but please do hold them to the after the presentation is over. So I think this crowd is familiar with all of our recent guidelines that we have for dyslipidemia management, as well as ASCVD prevention. What I really want to focus, or the take-home message of showing you this slide, is that all of these professional organizations, as part of their introduction to their guidelines and recommendations, emphasize the importance of a healthy lifestyle and helping our patients achieve a healthier lifestyle throughout their lifespan to decrease their risk for ASCVD as well as other chronic diseases. And again, I know this crowd has already heard that message before. The other positive thing is that all of those professional organizations also make the same recommendations for nutrition, for evidence-based nutrition recommendations. So this is based on evidence, and it's not as confusing as sometimes media likes to make it seem. First and foremost, the nutrition recommendations all emphasize an increased intake of plant-based eating. So more fruits and vegetables, legumes, also known as pulses. That's your lentils, your beans, split peas, those types of things, nuts and whole grains. All of the recommendations include emphasizing reducing processed foods. So when we're talking about healthy protein foods, encouraging people to, whatever protein they're eating, whether that's animal-based or plant-based, as minimally processed as possible. And clearly we want people to eat more fish, seafood, especially fatty fish, to eat more of the omega-3 fatty acids, the EPA, DHA. All of the recommendations from these professional organizations emphasize reducing saturated fat intake to less than 10%, sometimes less than 7% if a person has dyslipidemia already, the total calories there, and then replacing the decreased saturated fat, replacing it with mono and polyunsaturated fats. So they all also recommend using plant-based non-tropical oil. So in that effort to reduce saturated fats, having people replace it with non-tropical plant-based oil. So those liquid oils at room temperature, like extra virgin olive oil, canola oil, safflower oil, instead of the solid fats at room temperature like butter, lard, coconut oil, palm kernel oil. So that's all of those recommendations encourage that, and that's kind of an easy tip that you can tell your patients. All of the recommendations suggest decreasing intakes of dietary cholesterol and salt and sodium, and then reducing intake of processed foods like processed meats, refined carbohydrates, foods and beverages with added sugars. And if your patients do drink alcohol, making sure that they're limiting their intake to moderate consumption, which is less than 1 drink a day for women and less than 2 drinks a day for men. And that's of any type of alcohol. Trans fat should be avoided, but that's getting easier because it's being taken out of our food supply. And then all of the recommendations do emphasize following a healthy dietary pattern. A couple of them specifically mention Mediterranean, but there's also the dietary approach to stop hypertension, or the DASH diet, and then plant-based diet, or vegetarian, you'll also hear it called vegetarian. So any of those dietary patterns are recommended in our guidelines, but I want to spend a few minutes talking about the Mediterranean dietary pattern a little bit more, because it's really the only healthy or recommended dietary pattern that we have the strongest evidence for in terms of coming from both randomized controlled trials as well as observational studies. So I'm pretty sure most of you are familiar with Predimed by this time. Just a quick review, about 7,500 people. They were randomized. They did not have cardiovascular disease. They were a higher risk for cardiovascular disease. They did not have it already, so primary prevention. They were randomized to either a Mediterranean dietary pattern with supplemented with extra virgin olive oil, the Mediterranean dietary pattern with mixed nuts, or a traditional Mediterranean dietary pattern. They were counseled to lower their fat intake. It was supposed to be a low-fat Mediterranean dietary pattern. Didn't quite make it to what most of us think of as low-fat, which is less than 30% of your total calories coming from fat, but some reduction in fat intake. It's about 5 years long. Primary endpoint was the rate of major CV events, hard MACE, basically MI, stroke, and CV death. So the results, and again, I'm sure many of you have heard this already, but in both of the Mediterranean dietary pattern groups compared to control, there was a reduction in the composite CV endpoint, mostly from decreased risk of stroke, but about a 30% reduced risk in that composite CV endpoint. So now we have a secondary prevention study. It was published, the results were published this year, so some of you may not have heard of it, but the CardioPrev study was finished and published. It was done in patients with coronary heart disease, so about 1,000 participants, and they were randomized half to the Mediterranean dietary pattern and half again to a lower fat dietary intervention. So traditional Mediterranean dietary pattern, but it was supposed to be low fat. Again, didn't quite make it to that reduction of less than 30% total calories coming from fat, but a lower amount of fat compared to the Mediterranean dietary pattern. About 7 years for its median follow-up, and the primary endpoint was composite major CV events. So MI, revascularization, ischemic stroke, PAD, and CV death. So hard MACE plus soft MACE, essentially. The results also showed a reduced risk of CV endpoint by about 25%. If you look at the paper itself, they did multiple adjusted models, and in all of those adjusted models, there was about a 25% reduction of the CV endpoint. So now we have 2 studies looking at the Mediterranean dietary pattern, randomized controlled, primary prevention as well as secondary prevention, and both showed quite a reduction in the risk for CV events. So that gives us that stronger evidence to say, this is something that we can encourage our patients to follow and achieve reduction in both primary and secondary prevention. So this is a slide that shows this is the CardioPrev dietary recommendations. The Predimed recommendations were very similar. And so with the Mediterranean dietary group, again, it was not a low fat, it was about 40% total fat. The low fat dietary intervention was about 32%, but I really want to highlight the differences in the food choices. So the most important thing, I think, is that with the Mediterranean dietary pattern, yes, it was higher in monounsaturated fatty acids. Both of these dietary interventions were actually less than 10% saturated fat at study beginning, and at the study end, they were both about 8 to 9% saturated fat of total calories. So Both of them were actually similar in terms of saturated fat intake, but the Mediterranean dietary pattern was had a higher amount of foods that we know also provide nutrients, vitamins, minerals, fiber, non-nutrients like polyphenols and bioactive compounds. So really, and then again, those higher amount of unsaturated fats compared to the lower fat group. So I really think it's important that as we're talking with our patients about healthy dietary patterns that we want to encourage them to follow, maybe instead of thinking about it as this is the Mediterranean dietary pattern and this is the DASH, let's start looking at the food components in all of the healthy recommended dietary patterns that we want our patients to eat more of. And I'll talk about that more in a few minutes, but I just wanted to show you the difference in the dietary interventions in cardio. Can I have someone please mute your microphone? I'm hearing some noises from your microphone. So this is the healthy dietary pattern slide that I wanted to show you. And it really does, I think, really emphasize the commonalities in both the foods we want people to consume more of, because they are going to carry, again, the nutrients and non-nutrients, bioactive compounds, polyphenols, fiber, that we know are associated with improved cardiometabolic outcomes and decreased risk for ASCVD. So fruits, clearly whole preferred, vegetables less processed, of all of these different types of foods, without added sugars, without added salts, those types of things. Whole grains, nuts, seeds, plant proteins, fish or seafood, again, twice a week if our patients can consume fish or seafood twice a week. If they're choosing other animal products, making sure that they're lean and lower in fat, using non-tropical plant-based oils, like I mentioned earlier. And then all of them are really, emphasizing what foods and nutrients to try to limit to decrease the negative health outcomes. So processed meats, saturated fats, trans fat, refined grains, and foods and beverages with added sugars. And again, if someone's choosing to drink alcohol, having a conversation about what that means in terms of moderate alcohol intake, fewer than one or fewer, less than one drink a day for women, and no more than 2 drinks a day for men. So moving on to nutrient interventions and other lifestyle interventions for hypertriglyceridemia, I really will focus mostly on nutrition, but I really think it's important, and I will mention other lifestyle interventions that you can consider talking about with your patients and encouraging them to practice if they're not already. So first and foremost, the things we want to consider when we're discussing patients who have hypertriglyceridemia, and that's really identifying those who may also be at an increased risk for ASCVD. So those are the patients that greater than 150 milligram per deciliter to less than 500 milligram per deciliter fasting triglyceride level. Those are the patients that really will probably need to be on a statin as well, following their non-HDL-C or their ApoB, making sure that those other lipoprotein lipids are where they need to be. For patients who have severely elevated triglyceride levels at 500 milligrams or more, and I'm sure, again, most of you know this, if not all, pancreatitis then is our first concern with these patients. So that's what we're going to target. But then, once that risk of pancreatitis comes down, we really want to make sure that those patients aren't also at an increased risk for ASCVD. So looking at the rest of their lipid profile and identifying if their non-HDL-C or their ApoB is elevated, and then managing that accordingly. I'm sure all of you have remembered that we want to identify secondary causes in our patients with hypertriglyceridemia. That could be lifestyle factors, which we'll talk more about because most of those are nutrition. It could be lack of physical activity, though, possibly sleep. We're kind of starting to see some research that's indicating sleep might be an issue. Medical disorders such as hypothyroid, liver diseases, kidney diseases, making sure those are managed accordingly. And then obviously there's medications that you want to identify that may be contributing to hypertriglyceridemia. Once all of those have been assessed, and especially with the lifestyle factors, we want to individualize the approach. And, Guy and I were talking about this a little bit before everyone joined us, in the sense of, you have patients who yeah, their triglycerides are less than 500, so they're kind of easy to work with, and you know what you're doing in terms of lifestyle intervention. But what about those ones where you're just like, I don't know what's going on with them? And so I spoke with Dr. Kevin Mackey. He's our current president, who is also my boss at Midwest Biomedical. And it was really interesting talking through this presentation with him, because it helped me identify what I struggle with actually as a registered dietitian nutritionist, in that, you know, sometimes we see recommendations that just put people into buckets and say, okay, in this bucket, this is the dietary intervention that you should follow. And if you're in this bucket, this is the dietary intervention you should follow. And it doesn't necessarily kind of give us a little bit more to work with in terms of individualizing the approach. So after talking with him, it made sense to me to create maybe a little bit different way to look at hypertriglyceridemia. And one of the things that we discussed is determining if a patient has chylomicronemia in the presence of that hypertriglyceridemia, because then if we're going to put patients into buckets, that helps guide us, I think, a little bit better in how we're going to manage those patients. So if we ask the question, is chylomicronemia present? Please mute your microphone. Thank you. If chylomicronemia if it is not present, and typically that's with a triglyceride level less than 750 milligrams. So then a lot of the times that's an output issue. So maybe there's too much triglyceride coming in and the liver can't keep up, or it's packaging and creating more of the VLDL that's going out into the bloodstream. And then that's where we're getting that elevated triglyceridemia, not necessarily chylomicronemia present. So then with those patients, we have to figure out what the contributing factors are. There could be some underlying genetic disorders like familial combined hyperlipidemia, maybe some familial hypertriglyceridemia. Maybe it is just a person who has some extra body fat that they need help with managing, or maybe a little too much alcohol beyond the moderate, but not an excessive amount yet, or too much fruit juice or whatever. So those types of patients, it's really identifying what are those contributing factors that's causing an excess output of the triglycerides, and how can we manage that? That's going to be different than if we have a patient who has chylomicronemia present, and that's typically at a level where triglycerides are 750 milligrams above or over, and typically for sure if they're at 1,000. So with those patients, now we're really looking at more kind of a genetic predisposition. Again, not always. So it's really individualizing, investigating, asking questions, family history, maybe taking more lipids to identify. And typically if a person Guy and I were talking about the patients with lipoprotein lipase deficiency, those are our patients that are typically going to be familial chylomicronemia syndrome. And those are the patients that for sure need a very low fat dietary pattern, which I'll talk about more in a minute, because their output is out of control. The systems, pathways that are managing their triglyceride levels or the chylomicronemia, they're saturated and they can't do their job anymore. So if we're really going to, again, if we're going to put patients into buckets, I think this is a more helpful approach in the sense of if a patient doesn't have chylomicronemia, then we're going to go down one route that might be a little more moderate, especially in terms of, say, fat content or dietary restrictions. If a patient has chylomicronemia, 750 or above, for sure over 1,000, then those patients are the ones that we really are going to clear those chylomicronemia, the chylomicrons in their blood, and then kind of see from there what we need to do. So let's talk about that a little bit more. So with the lifestyle therapy for triglycerides below 750, of course, I'm going to give a shout out to, if at all possible, refer to a registered dietitian nutritionist. Even with these patients, they're going to need some support in helping them figure out what lifestyle interventions are going to work best for them. In terms of specifically, if they're consuming alcohol, clearly we want them to reduce their alcohol intake, complete abstinence if their triglycerides are above 500. with people who have high levels of triglycerides, again, not necessarily above 750 yet, we're talking about them in a minute, but total carbohydrate intake limit is important. So restricting their intake to about 40% of their total daily calories coming from carbohydrate. Doesn't need to be ketogenic. I think we've seen very often that people can achieve improvement in their triglyceride levels without having to reduce their carbohydrate intake to such a severe restriction. So about 40% of their total calories coming from carbs does allow them some flexibility in their eating pattern. The important thing is emphasizing the quality of that carbohydrate. So really encouraging our patients to eat the fiber-rich carbohydrate foods that we talked about earlier, coming from those evidence-based nutrition recommendations: whole grains, fruits, vegetables, as minimally processed as possible, nuts, seeds, legumes. Those are the carbohydrates that we know will, have a lower glycemic index, if you will, if you want to use that term, are metabolized more slowly, and do not tend to increase triglyceride levels. Clearly, we want people to reduce their intake of refined carbohydrate foods. And I need somebody to mute. Maybe I can do that for you. I cannot. Kathy, could you please?
Yes, I did that.
Thank you. So again, encouraging our patients, talking with our patients about reducing their intake of foods and beverages with added sugars. And there is some evidence that as we're asking patients to reduce their intakes of carbs to a more moderate amount, replacing it not just with unsaturated fats, that's definitely an option. We see that with the Mediterranean dietary pattern, actually, with CardioPrev. It was a reduced carbohydrate dietary pattern as well, but also lean plant and animal protein foods can be an option as we're working with our patients to decrease their triglycerides by modifying their macronutrient intake. So that Mediterranean dietary pattern is definitely an option for patients who have hypertriglyceridemia. There's actually studies that show people following the Mediterranean dietary pattern have a reduced amount of triglycerides. But the DASH can also be modified, the dietary approach to stop hypertension. It can be modified to be a more moderate carbohydrate intake and bump up, again, the lean protein and the unsaturated fats to replace that carb, as well as the plant-based dietary pattern. Any of those can be modified to be more like lower or moderate in carbohydrate and be a good fit for patients with hypertriglyceridemia. Physical activity clearly is important. Triglycerides actually are the lipid that responds most quickly to physical activity. And so if we can get our patients to be active a little bit even every day, that is what's going to help with that triglyceride level coming down and being maintained at a healthier level. Not all patients with hypertriglyceridemia have weight to lose. Some do for sure, and that can contribute to hypertriglyceridemia, but it's really important that we really work with our patients. Some patients do have a genetic disorder, more often with the elevated, severely elevated above 1,000, but really if a person does have body weight to lose, then that can help with improving their triglyceride levels. 5 to 10% weight loss can decrease triglycerides by about 20%. And in terms of lifestyle, therapeutic doses of EPA and DHA, 2 to 4 grams a day, we all know can help reduce triglycerides. Most people are not going to get that from nutrition intake. So that's where you're going to have to work with your patients. I know we want them to take a prescription EPA, DHA before they take a dietary supplement. Some people can't afford that, especially because sometimes prescription EPA, DHA is not covered by insurance. So really working with your patients if they're going to choose to take a dietary supplement and make sure that it's a reputable one, USP verified, all that good stuff. So I like this table from the 2019 ESC/EAS guidelines for the management of dyslipidemia because I just think it's a good illustration of what we're going to get in terms of magnitude of effect from these different types of lifestyle interventions. So clearly, if a person is drinking alcohol and we can help them reduce that intake, that's going to give us the highest magnitude of effect. And the legend down here shows you that it's going to be about greater than 10%. That's going to depend on how much they're consuming. But for some people who are consuming quite a bit, that's going to be a big impact. And then all of these others, you'll notice, and they can have a cumulative effect. So that's where I like to show people, let's look at what's going on with each patient, individualize that approach. If they need to reduce their dietary carbohydrate intake, that's going to have a decent magnitude of effect on that triglyceride level. Improving their physical activity is going to have the same effect. Replacing or reducing the amount of added sugars clearly is going to have a beneficial effect. So talking with patients about and identifying with them in your conversation of, what can we choose first to make an impact on your triglyceride levels? Let's get that figured out. Let's take the next step, but showing them that there's multiple things that they can do to have a positive effect on their triglycerides. So this is just a nice illustration of the importance of reducing carbohydrate intake. And this is a study that was done quite a while ago, and it was in healthy participants, obviously a very small sample size, but they went through a 2-week dietary intervention where they followed a 60% carbohydrate diet, 2-week washout period, and then the next 2 weeks it was the reduced carbohydrate, so 40% carbs. Fat obviously varied between the two, but protein was the same. And then what I thought was interesting is that the researchers measured fasting as well as postprandial lipids over the next 8 hours after that fasting lipid profile. So this is the results. And again, this is in healthy people who don't have metabolic issues, but that reduced amount of carbohydrate did keep the triglyceride level lower compared to the higher amount of carbohydrate. Clearly, the remnant lipoprotein, triglyceride, and cholesterol was impacted as well. HDL came up. That doesn't surprise any of us because HDL usually comes up or is elevated when triglycerides are lower. So LDL stayed the same. Again, not typically a surprise for any of us. What I also thought was interesting because, again, people who are following a low-fat diet, sometimes it's believed that, well, that lower fat intake, that's going to keep, over the course of the day, that's going to improve their lipoprotein lipids. And in fact, it did not. The elevation from the higher amount of carbohydrate continued throughout the next 8 hours. Now, I am not saying that everybody has to follow a 40% carbohydrate dietary pattern, but I am saying that we need to be aware that a higher amount of carbohydrate in some people is not necessarily going to be the best choice. And if somebody is choosing that amount of carbohydrate, then really emphasizing the high quality fiber-rich carbohydrates for those patients. So when you're having your conversation with patients, and this is with patients that we know have that less than 750 milligrams, but having conversations with patients with a higher amount of triglycerides is important too. Creating that rapport, creating that safe place to have these conversations, but identifying from patients what types, again, of lifestyle or nutrition habits they're doing that could be contributing to their hypertriglyceridemia. So asking open-ended questions as much as possible about their their food intake. Maybe they're consuming the higher amount of sugar-sweetened beverages or simple sugars that they're adding with their meals, or sweets, alcohol, clearly. If they're not active, asking that question and then talking through what they could do to improve their activity. And then definitely asking about their weight history to see if that has been a factor for their elevated triglycerides. But the main thing is it important, especially if you don't have access to a dietitian or to get the conversation started, asking those open-ended questions and identifying where they're willing to start addressing their nutrition or lifestyle habits to improve their triglyceride levels. So with patients who have elevated triglycerides over 750, again, these are the patients that typically have chylomicrons. And so the first thing, and this is probably patients where the medical team is going to be involved in the sense of identifying if they have abdominal pain or pancreatitis, should they be admitted to the the hospital. Typically, these patients are going to be NPO, or for sure have them follow a chylomicron clearing diet to really get those triglycerides low. Referring to a registered dietitian nutritionist actually is really critical for these patients, especially after their triglycerides, after they follow the chylomicron clearing diet, it's my dinner time. So I'm going to start having some low blood glucose issues. Anyway, I'm mountain time. So it's like right at my dinner time here. But after those chylomicrons are cleared, if their triglyceride levels are still very elevated, then that is a sign that they probably have a genetic issue, a lipoprotein lipase deficiency, ApoC2 deficiency. Something is contributing to that elevated triglyceride, the chylomicron elevation. Those patients are going to be the ones that really have to have support because they are going to be following some nutrition restrictions, some nutrition recommendations that are very restrictive. And they may have some other comorbidities. Maybe they have diabetes that's associated with multiple bouts of pancreatitis. Whatever, it's important to have a registered dietitian on board to provide medical nutrition therapy to help them be as successful as they can. So in looking at a dietary pattern for patients who do have, say, familial chylomicronemia syndrome, it's really, and regardless if they have a history of that severe elevation in triglycerides, elimination of alcohol completely. And so if this is a patient who is suffering from alcohol use disorder, then getting them the support for that as well to have that long-term success. These are the patients who have to follow a very low-fat diet. Whereas other patients that have, 750 milligrams or lower, and even after maybe the chylomicrons are cleared and we see that they have a lower amount of triglycerides, those are the patients that we want to work with to see if they can have a more moderate kind of dietary pattern, that lower carbohydrate, but a moderate more amount of fat. Patients who have FCS or other disorders that are contributing to severely elevated triglycerides cannot. They can't have a high fat diet, has to be very low fat. And that is very difficult to follow for one thing, but also puts them at risk for some nutrition deficiencies, specifically the essential fatty acids. It's difficult because with their dietary pattern, because they have to follow such a low fat diet, they're going to have a higher amount of carbohydrate intake. And so having that dietitian support to help them create those meal plans so that they can be successful is going to be important. Some patients may need fat soluble vitamins and mineral supplementation. Many patients will benefit from medium chain triglyceride supplementation. It has to be medical grade because some of the medium chain triglyceride products that you can get on over the counter dietary supplement have more lauric acid. So really looking at your medium chain triglycerides and making sure it's true medium chain fatty acids, capric and caprylic, the 8 and 10 carbons, not the 12 and higher. And physical activity is important for them as well. They may benefit or need a higher amount of activity each week to help bring their triglyceride levels down, chylomicrons down. And again, weight management, weight loss if appropriate. And clearly these patients are going to be on something, some pharmacotherapy, but these are specific to the lifestyle therapy for these patients. So this is a tear sheet that you can access from the FNLA. It's important that you use this website to access this particular PDF. We have been updating our tear sheets, and this is the one that I don't think you can access on our website currently. So type in this URL. I know it's super long, but that's the way you can get to this specific. You can also Google chylomicron clearing diet, I think, and access that as well. So intermittent fasting, I know we want to have time for Q&A. So I know Guy had told me some people had some questions about when should I use intermittent fasting with my patients? And so first and foremost, it's defining what that means for your patient, because there's multiple definitions for intermittent fasting. I think most of us are familiar with time-restricted feeding, and that's where a patient chooses to limit their eating window to say 4 or 6 hours during the day. So then they're fasting for the rest of the time. And in terms of the evidence, I think it's important that we know, compared to a standard diet or no intervention, yes, there's improved weight loss in patients. And this is patients with diabetes. This is also patients without cardiometabolic issues. So in either group, compared to no intervention or say a standard dietary intervention, better weight loss with intermittent fasting, and that's multiple examples, or I guess choices with your intermittent fasting. Decreased waist circumference, LDL cholesterol improved, and systolic blood pressure improved. However, there wasn't a difference in any of the other cardiometabolic risk factors compared to continuous energy restriction. And this is where, you know, we work with patients just to have them reduce their intake of calories over the course of the day. There was actually no difference in weight loss or those other cardiometabolic risk factors in participants with or without diabetes. So do I think we should never have a person follow intermittent fasting? That's not what I'm saying. I'm saying if it's an option for patients, if they feel like it's going to fit with their lifestyle, with their particular preferences, then, you know, compared to continuous energy restriction, it's going to be as good. And some people really like the intermittent fasting, and they feel like they feel better with using the intermittent fasting. So if it does work for them, fantastic. I just think it's important that we know that for, you know, based on the evidence that we have right now from systematic reviews and meta-analyses, it's not necessarily better than the continuous energy restriction. So really working with your patients and seeing if it's a good fit for them or not. So in wrapping things up, I think many of you are familiar with the AHA's Essential 8 that was just published this year. They added, it used to be Life Simple 7. They've added a new behavior, which is achieving healthy sleep. So I think it's important that clearly nutrition can have a huge impact on a person's risk for ASCVD. Clearly something like hypertriglyceridemia, nutrition plays a central role, but we cannot forget, and we really need to emphasize and address these other health behaviors, being more active, which again, I mentioned with working with patients with hypertriglyceridemia, encouraging them to be more active, but just in general, that's important for CV health. Clearly avoiding tobacco. And again, I think we have a lot of information and research now that shows the importance of healthy sleep. And all of those health behaviors then can affect the health factors that we want to help our patients achieve a healthy weight, controlling their blood lipids, managing their blood glucose, and managing their blood pressure. So all of those clearly can sometimes require pharmacotherapy, but they can all be influenced by those health behaviors as well. So working with our patients to achieve those healthy behaviors. So our take home, we have multiple dietary patterns. Whatever we call the dietary pattern we want our patients to follow or they want to follow, really they have the commonality of increased intake of plant-based foods, lean protein foods, whether that's animal or plant-based proteins, using non-tropical oils in place of solid fats, again, limiting the foods and beverages with added sugars. The nutrition recommendations for hypertriglyceridemia should be individualized, and really kind of thinking about that, is chylomicronemia present or not, can help us identify the etiology and hopefully determine the best approach for our patients. Referral to a registered dietitian nutritionist, especially with the patients who have severely elevated triglycerides, really is a strong recommendation. And then addressing those other health behaviors that our patients may need help and facilitation in improving healthier physical activity, sleep, etc., to achieve those improved health factors. So I want to thank Dr. Mackey for having the conversation with me and reviewing my slides. Continue to learn so much from him. And I think we have time for questions.
Thank you, Carol. That was great. So if people have questions, you can either put them in the chat box or unmute your mic and keep the question short and sweet. One question that came up, Carol, is there any role for MCT oil? How would you use it? What would be the dosage? And do you use it?
So with the MCT oil, I spoke a little bit about that on the slide for people who have severely elevated triglycerides. And I will be honest, I am not an expert in working with patients who have severely elevated triglycerides. I live in Idaho, and we don't have a whole bunch of people here. And I'm not currently working with patients. However, the FNLA published, or the JCL published recently, and I can send whoever asked that question. There's a great paper on working with patients with FCS, and I believe they mention using MCT and how you might use that. So whoever asked that question, if you want to reach out, I can either email that PDF to you or get you connected with some of the authors who can answer that question better than I can.
Great, thank you. There's something in the chat regarding, have you used meal replacements for patients with very high triglycerides?
I have not heard or seen any research on using meal replacements with high triglycerides. I think, you know, some patients use it. I know it's been used for, say, weight loss programs. I think it would depend on the preference of the patient. Guy, have you seen any use of, say, meal replacements in your practice?
Yeah, well, not so much in my practice, but the patients that we work with the bariatric group, they, you know, do start these patients on meal replacements with the weight loss, as you've pointed out tonight, comes reduction in triglycerides and lipids. But I'm not aware of anyone per se, you know, using a meal replacement for specific just high triglycerides.
So I think my, not concern, but what I would think about with meal replacements is, I think they could work. I mean, clearly they do, like your example with weight loss and that type of thing. But eventually our patients may need to stop using meal replacements. So I think with anything like that, it can be a short-term fix, and really working with them to transition them to being able to use regular foods or regular meals for their long-term success. Unless, I mean, if we're looking at a patient who has elevated triglycerides and, you know, that meal replacement is part of kind of what their management is, then I would say just making sure that the meal replacement is nutritionally sound, providing, you know, the nutrients and non-nutrients that they need.
I think that's a great point. And I've had many patients that have, you know, done Nutrisystem or Jenny Craig, and everything's, you know, great until they transition out onto regular food without guidance. So we have another question here for you. What reduction of LDL cholesterol would you expect to see with a DASH diet, or as well as what is the average duration of adherence with the various diets? Which is the hardest diet to adhere to, and which one might be a more easier diet for patients to adhere to? That's like a 3-in-1 question.
Right,
so.
I know. So
But,
in terms of the LDL cholesterol, there's actually been a few studies on the DASH. I mean, the first studies were done back in the 90s, and I honestly can't remember all of the numbers. It's discussed in the 2013 guidelines for cholesterol reduction, but since then, there's been additional studies and kind of looking at, you know, modifying. OmniHeart was one of those, so you could Google or get on PubMed and look for OmniHeart. But typically, because the DASH is such a very low saturated fat dietary pattern, you do see a nice drop in LDL-C. The early DASH studies, there, because it was higher in carbohydrate, because it was lower in total fat, it was about 27% total fat. Triglycerides did come up a little bit. So that's where then additional research really looked at kind of modifying the macronutrient intake. And so OmniHeart was, I think, one of the first ones. I know there's been some since that showed if we reduce the carbohydrate intake of the DASH, so kind of keeping the DASH framework, but reducing the amount of total carbohydrate, replacing it with lean proteins or unsaturated fat, you get even kind of a better benefit. And it's not a super low carbohydrate DASH diet. It's still moderate carbohydrate, but triglycerides come down, LDL-C still improved, so you still get the benefit. So I think that's a great example of taking a dietary pattern, DASH, and modifying it for your patient's needs, where you kind of work with macronutrient, balance that for what your patient needs, and it still can be a very healthy dietary pattern. Again, similar in terms of the food choices that you're going to see in the Mediterranean dietary pattern. So did I answer that 3-pronged question?
The last part of the prong was which is
Oh,
the hardest
adherence.
diet to adhere to and which might be the easiest diet to adhere to.
Got it. Good one. So adherence, and actually there was a study, the Keto Med, I'm sure by Christopher Gardner and his group. They actually published a paper on adherence for that randomized controlled trial. And they found, it was interesting. I think if we look at, say, our 2019 scientific statement where we did review the current evidence at that point, very low carbohydrate ketogenic diets are probably the most difficult to adhere to just because of the level of restriction. And what we saw in our review of the evidence was in all of the randomized controlled trials, we essentially looked at systematic reviews and meta-analyses that were already done. And in all of those randomized controlled trials that were included in the 13 plus systematic review and meta-analyses, there was one randomized controlled trial where the participants actually maintained the level of carbohydrate required for ketosis by study end. So to me, that shows that that severe of a restriction is probably the most difficult to follow. However, I think anytime you have patients who are looking at too severe of anything, it's going to be difficult for them to adhere to it. So any kind of, and we've seen that from other studies. Christopher Gardner again and his group have looked at, comparing the Ornish, the Learn, a low carb, it was Atkins, and one other, Zone, and all of them by the end of the year struggled with adherence. So I think it's important that we work with our patients not on just following some kind of diet, but really looking at, what is going on with their nutrition habits that they need to address and creating habits that are healthier to replace those. So if we have patients who are consuming, way too much sugar sweetened beverages, let's work on that because clearly that's going to have the biggest bang for the buck. So get them to decrease their sugar sweetened beverage intake, replace it with a healthier option. Water is always the best option in my opinion. But working with them on that, and then tackle the next thing. If they're not eating enough vegetables, encourage them to, or help them identify how they can consume more vegetables. So taking it kind of as a step-by-step versus here's this dietary pattern and that's what you have to follow. I think by helping them achieve healthier nutrition habits over the course of time that they can stick with, would help with their adherence. So hopefully that answers that one.
Yeah, that was
So
great.
let's see. There was a coconut oil question, and it really surprises me that we're still talking about coconut oil, but my opinion about coconut oil is that it is still being touted as heart healthy or, some great food, and it's not. It's the richest, highest food with the highest amount of saturated fat. So it's the most kind of saturated fat that we have out there. And I know a lot of the tout comes from it being rich in lauric fatty acid, which people say is a medium chain triglyceride. Technically, it is because it's in that group of 8 to 12 carbon chains, but it actually acts more like the longer chain fatty acids. It increases cholesterol levels. It's one of the most potent in terms of increasing LDL cholesterol. It doesn't go through the same pathway. It goes through the same pathways to get to our liver as the longer chain fatty acids. So it does increase atherogenic lipoprotein lipids. So I would encourage people to use it like they would use any other solid fat and limit its use and use things that we know, non-tropical plant-based oils in place of that. Do I like curry? Yes, I make curry. I eat curry with real coconut milk, but I do that as part of an overall healthy dietary pattern and not every single day. So do we have more questions?
Great. Just getting back to the DASH diet, reduction LDL cholesterol of 11 milligrams per deciliter. For those want to get that right.
Perfect.
Okay. Does anybody have any other questions for Carol? Because she's definitely ready to be having dinner soon?
Yes. So I do see a question from Dr. Karen Asprey. Hi, Karen. So with the road to diabetes with impaired fasting blood glucose, do you ever want to recommend consideration of metformin at the same time as your diet interventions? I think that is a question based on the individual. I think that's where the healthcare team really needs to come together, work with that patient. I would guess that there's going to be some patients that would require metformin at the same time as lifestyle, but there is going to be patients that would not. So where we can really give lifestyle a try. Clearly, the diabetes prevention program results showed that lifestyle can be effective in patients with prediabetes and delaying that. But clearly, we want to pay attention and really work with patients on an individual basis. Guy, do you have anything to mention or add to that?
Thanks, Q.
Yeah.
I think we approach it on a case-by-case basis because, sure, we can use medication, but we also need lifestyle change along the way.
Right.
But,
and that's both for sure. Lifestyle is the foundation, adding pharmacotherapy as needed. So in terms of Christopher Gardner, he actually didn't do the systematic review. That was the NLA scientific statement on low carbohydrate, very low carbohydrate diets. That's available at lipid.org. Just go under recommendations and statements. Christopher Gardner, his most recent study was the Keto Med. And that was just published this year. He has multiple other studies though.
and do you want to say anything from your study on low carbohydrate, a very low carbohydrate statement that the NLA came out with a scientific statement?
Well, I think it's just important that, and I kind of covered it with the discussion about with patients who have triglycerides less than 750, a moderate carbohydrate intake can be very effective for patients with triglyceride levels at that level, but also with, the patient that Karen brought up, patients with prediabetes, insulin resistance, metabolic syndrome. Those are really the patients who benefit the most. And we saw that in our review of the evidence. Triglycerides go down, glycemic control improves in those who have type 2 diabetes, but it doesn't have to be ketogenic. And so I think that is always my emphasis, or the take home I want people to hear. I'm totally on board with reducing carbohydrate intake in patients who would benefit, meaning the patients I just discussed, but really emphasizing they don't have to go on such a severely restricted carbohydrate intake. Most patients cannot maintain that. If they want to give it a try for, say, less than 6 months, because that short-term amount of time is where we actually do see more benefit with the really very low carbohydrate intake. But beyond 6 months, the benefit compared to a higher amount of carbohydrate pretty much wanes. So I think that's the key, is that, a lower carbohydrate intake can be very appropriate with some patients. We just don't have any evidence to support that a person has to be following a ketogenic dietary pattern or in ketosis to get those benefits. And so a more moderate, low to moderate intake is going to be more achievable for one thing, and more likely that people can follow it long-term and still get the benefit, because they're consuming those, high quality carbohydrates within that context of a reduced carbohydrate dietary pattern, those nutrients that we know are associated with benefit.
Terrific. So I think, Carol, you told us how to do it. And, I think for all of us as clinicians, certainly, utilizing lifestyle change, including exercise and weight loss, is easy for us to, motivate our patients to move on. But using the expertise of our dietitians and nutritionists are complementary to what we need to do with these patients, and actually all patients. So I want to thank you, Carol, for giving us your time and expertise, and appreciate you being part of our inaugural Neela Nights program.